This is Phil Gibson, Community Connection for the month of September, and we appreciate everybody's attendance and joining us. Today's topic is going to be on Parkinson's disease, and our guest speaker is Cheryl Sierfert. She's the Executive Director of Parkinson Association of the Rockies. Cheryl has been involved with different nonprofit entities, this one being her latest, but her activity started in this arena with her mother, who had Alzheimer's disease for a long time, and the privilege of caring for her was a great deal for Cheryl. So I'm going to kick this off with Cheryl and let her talk about Parkinson's disease and some of her background and experience. Cheryl, welcome this afternoon, and we really appreciate you being involved with Community Connections at People Care Health Services.
Well, thank you. It's an absolute delight to be here today, Phil. I'm going to go ahead and jump right into the presentation. Hopefully, if you for some reason can't see the presentation or you're calling in, Cheryl, I'm sure, do a nice job as far as explaining what we've got here. These slides and the link will be available to you on the website, so if you want to go back and review them after the presentation is over with, Devin will be placing those out there for us. So, Cheryl, it's all yours. Great, thank you, Phil. You know, as we start talking about Parkinson's disease, today we're going to be looking at how do we live with and manage both the motor and the non-motor symptoms of Parkinson's disease. But before we can get started, if we take a look at what is Parkinson's disease, essentially, Parkinson's disease is a movement disorder. So it affects the way our body gets from point A to B, as well as how our body responds to people talking to us, how my mouth moves when I smile, and all sorts of things like that. And what's happening is there's a chemical in the body called dopamine, actually in the brain. And we lack sufficient dopamine in the brain when we have Parkinson's disease. And the effect of that is it affects our slow muscle movement. And we'll talk more about what that looks like in just a minute. About 1 million Americans have Parkinson's disease, and we estimate that 17,000 Coloradans are living with that. So you are bound to know somebody or a friend of somebody who is living with Parkinson's disease in Colorado. Essentially, it's a disease that's associated with older people, so to speak. I don't necessarily think I think that's older, but people over 60. It's diagnosed in the early 60s, but it's not limited to people in their late 50s and early 60s. We've seen Parkinson's disease in people as young as 20, 30, 35. We refer to this as a young onset Parkinson's disease. So let's begin to look at the symptoms of Parkinson's. We always think of Parkinson's disease as having tremors. And with the tremors, that's the most obvious when we see it. But before the tremors, in order to have Parkinson's disease, you must have bradykinesia, which is slow movements. And when we begin talking about slow movements, we mean you're not walking as fast. What we'll see is that one side of you, maybe the gait or the movement on the foot of one side or leg on one side, is shorter than the other. But those aren't the only motor symptoms in Parkinson's. As we talked about, let's go back to that tremors. Tremors in Parkinson's are obvious for those who have it. Not all people, reminder, not all people with Parkinson's will have tremors. But if they do, it's what we call a resting tremor. And by a resting tremor, we mean that it's a tremor at rest. So if you have your hand sitting on your leg, you might see a little bit of a tremor. If you are showing a tremor that is inactive, otherwise while I'm doing things, I reach out with my hand, that is probably an essential tremor and may not be Parkinson's. The tremor in Parkinson's also begins on one side of the body, so perhaps it's a right dominant or a left dominant, and the tremor could be in your leg and not necessarily your hand. The other thing that happens with the motor symptoms of people who are living with Parkinson's is we see poor gait and balance. Typically, as the disease progresses, we see a posture that is leaning forward a little bit. because our balance, our core that typically keeps us standing upright is beginning to be compromised. The other thing that's interesting is we'll see either a shuffling or a running walk with Parkinson's. People look at me and they say, a running walk. Had an interesting experience with some of our constituents, one who's a golfer, who would talk about running. He'd get out of his golf cart and he'd go across the fairway, and he actually had this running walk. And this can be part of Parkinson's. When people with Parkinson's fall, they also generally fall forward. I bring this up because there's some related diseases to Parkinson's, and those related diseases include things such as progressive supranuclear palsy, which is probably the most closely related, and people with that disease will fall backwards as opposed to forward. The other thing we see is rigidity in people with Parkinson's. When we talk about rigidity, there's a ratcheting. And when I say ratcheting, we mean that, like, when you're moving your elbow up, it's kind of like it keeps hitting a little kink on the way up. So quite often a doctor, if they're examining you, will place their hand on your elbow area, and they'll ask you to raise that hand up, and they will feel a very slight kind of catch as it's going up. One of the most common features and poorly misunderstood in people with Parkinson's is this masked face. Now, if you think about it, and you think about Parkinson's affecting slow motor movements or the slow motor muscles, this makes sense. We don't often think about how important our slow motor functions are, but they are what give us our smile, what make our eyebrows move. They're responsible for just everyday walking, getting up and sitting down out of a chair. So without the slow motor muscles working properly, we get this masked face, as you see in the photo here, where there seems to be no expression. And so consequently, when people are interacting with people with Parkinson's and vice versa, quite often they assume that they're disinterested and they're kind of, you know, not paying attention to them because they're not showing the typical nonverbal communications that come with one's face. So let's take a look at what exercise as the essential treatment for Parkinson's is. Exercise, and we're going to focus on this because most of the individuals with Parkinson's that we run into probably have already seen a physician and have already gotten the medicines prescribed that will help them with Parkinson's. At the same time that medicine is prescribed, the first thing that should be prescribed to people with Parkinson's is exercise. It is literally an essential treatment. So why is it the best medicine that's available? It's because it slows down the progression of Parkinson's disease. I'm going to repeat that. Why is it the best medicine? Because it slows down the progression of Parkinson's disease, and it's something that a person living with Parkinson's disease, or even a family member helping a person with Parkinson's disease, or professional caregivers, they can really help individuals living with Parkinson's disease by promoting their engagement in Parkinson's disease. So the first question is, how much and what type of exercise should we be looking at? Well, I'm going to give you the common things that people tell us. Exert yourself. Raise your heart rate and break a sweat. A minimum recommended of 30 minutes per day and 5 days per week. Those of you who are perhaps a little older, have been couch potatoes in life, don't exercise a lot, are going, whew, no way. I can't do 5 minutes a day. excuse me, 30 minutes a day and 5 days a week. That's just not going to work for me. And besides that, I hate exercise. So I want to talk to you about just getting started. Let's just get started with exercise. So how do we do that? I want to tell you a story. I used to weigh about 70, 80 pounds more than I weigh today. And I decided one day I was going to lose weight. And so I went out and I bought myself a stair stepper. I wasn't going to a gym. No way was I going to a gym. So I bought this stair stepper. First morning, I hopped on that stair stepper. I started stair stepping, and I was stair stepping for 2 minutes. I thought I'd die. I mean, I did. I thought I'd die. So I got off that stair stepper. But I was determined. I needed to lose weight, and I knew I needed to exercise. So the next morning, I got on that stair stepper, and I stair stepped for 2 minutes and 15 seconds. And oh my goodness, I thought I was going to die again, literally die. Well, I just kept doing it, and eventually I could what? Stair step 20, 30 minutes. I lost a tremendous amount of weight. And as I started losing weight, people said to me, "What are you doing?" I said, "I'm stair stepping." And they said, "Oh, how long are you stair stepping?" Okay, here is your first warning. Don't fall into these traps. If somebody is asking you how long you are exercising, how much you're doing, they pretty well have a thought about how much you should be doing. So, here's my clue. When you first start exercising, whatever it is, and somebody asks, "Well, how long are you doing it?" The answer is always just enough. It's just enough. Because if you give that answer, they have, they can't give you advice that it's not enough, that you should be doing more. So as you get started, don't compare yourself to others. Don't compare yourself to, you should be doing 30 minutes a day, 5 days a week. Compare yourself to yourself. And make sure that what you did, what you do today is just a little bit more than you did yesterday. And keep stretching yourself just a little bit at a time until you reach your goal. I give this advice because exercise is imperative to the well-being of those living with Parkinson's disease. Absolutely imperative. And the reason being is it improves balance, it improves gait. The minute we improve balance and gait, you're going to reduce your risk of fall. You're going to feel much better, and you will be able to literally thrive while living with Parkinson's disease. So make sure you get exercise on that regimen. Let's move on and talk a little bit about freezing. Some of you may experience what we call freezing. Otherwise, you may be standing in place and you're shuffling your feet, but not going forward, not going backwards. You are literally stuck. This tends to happen in small spaces, such as doorways, or it can happen in large crowds when you're anxious or stressed. Sometimes, think about it, it happens in elevators. You go to get on or off the elevator, and you feel that you're going through this doorway. You'll notice a picture of what we call a U-step walker here. A U-step walker for individuals who are having walker problems is a great piece of adaptive equipment because it helps with many cueing factors that help you cease to get unstuck, to get unfrozen. For instance, audio cues. And you can do these without a U-step walker, obviously, but an audio cue such as a metronome. Most people don't walk around with a metronome, so maybe it's a clapping of the hands in a beat to just get you walking and thinking about rhythmic. They're visual cues. You'll notice the U-step walker here has a red line, which is a laser beam. Now, we're not quite sure why it works, but the red laser beam triggers the brain differently. So when a person with Parkinson's looks down at that U-step walker, they can, focus on stepping over the line. We have a great story of a woman. We were doing a program once at the Parkinson Association on mobility issues, and we happened to have a U-step walker with us. And she had come to the program, and she had major problems with freezing. And not only major problems with freezing, I mean, she was using a standard walker at the time. Well, at the end of the program, she came down to check out the U-step walker that we had shown at the event. She grabbed onto that walker, and all of a sudden headed to the back of the room like you wouldn't believe. I mean, with a walk that was rhythmic. It kept her moving forward. She was walking faster. As a matter of fact, I had to run and catch up with her and say, hey, listen, it's okay. You can borrow the walker from us. That's not a problem. I just need your name. So it's amazing what a piece of adaptive equipment or some of these visual cues use. So how do you do that if a person doesn't have a U-step walker? You find a line on the ground. If you happen to have a laser pointer, put the laser pointer on the ground and see if you can create a line or a visual cue for them. There are also some movement tricks that can help if you don't have a walker with you and you're suddenly stuck. Whether you're a family member or a caregiver who is trying to help a person move forward, or the individual with Parkinson's. A lot of times people will try taking a step backwards first. Don't focus on going front, try and take a step backwards. Or they'll rock from side to side to get the body weight to change. As you're walking, or even from a somewhat mobile position, if you move your hip, move one of your hips, begin a little bit of a turn with the hip, and relax your leg, let it follow. Many times it will follow through in order to get those legs moving. The last thing that's a great trick if you are experiencing freezing or other gait problems that isn't mentioned here is the use of walking poles. Walking poles are marvelous. They keep you, they lengthen your stride, they keep you moving because you're using your whole body more, you're getting a better arm swing. So trekking poles are absolutely great. You can always look online and write walking poles or pole walking with Parkinson's and find some great demonstrations. So we've talked about some of the motor symptoms, but let's take a look at what I call, the full picture of Parkinson's. And on that full picture of Parkinson's are all the non-motor symptoms. So we've only hit the tip of that iceberg. Check out the non-motor symptoms that people with Parkinson's can experience. Things like dementia. We can get a psychosis that goes with it. Drooling, and that is very bothersome to people with Parkinson's, as is a runny nose. Fatigue, constipation, pain, insomnia. There can be urinary frequency, depression and anxiety, apathy, sexual dysfunction, hypertension, orthostatic hypertension, standing up and becoming very dizzy, restless leg syndrome, just all sorts of things. So we want to spend some time looking at the non-motor symptoms of Parkinson's disease. And the reason for this is these are often under-recognized and they're under-treated, in all honesty. We quite frequently, as an individual with Parkinson's disease, we don't mention them to our physician. And when we're caring for people with Parkinson's, we don't always notice this. But these are the things that individuals living with Parkinson's come to me and they say, Cheryl, I can live with the tremors. I can live with a masked face. I can, overcome some of the freezing. But these non-motor symptoms, they just really get me. One of the first non-motor symptoms that occurs is this loss of smell. And it's interesting, while there isn't a cure for this, it is often the first symptom of Parkinson's disease. So when you talk with somebody with Parkinson's disease and they learn that this is one of the symptoms, they'll often say, I haven't been able to smell a thing for 30 years, Cheryl. Well, most likely when they looked at the doctor and they said, I'm beginning to have, I'm beginning to sense that my sense of smell is kind of becoming less acute. It's not working as well. And a lot of times, depending upon how old you are, the doctor says, well, you know, there's not much we can do. If you've got gray hair, they'll probably say, oh, you're just getting older. Well, in fact, we need to explore that first symptom some more with the doctor and not just assume it's a fact of aging. Because one of the things around loss of smell is we have a decreased appetite, you know, and with a decreased appetite, obviously that robs us of one of the greatest social functions there is, and that's enjoying our meals with friends, families, you know, colleagues, whomever. It just takes a little bit of edge off that experience. The next motor symptoms that are probably the most bothersome to people are drooling and runny noses. So we look at drooling and runny noses, and the first thing people think is, well, it's an overproduction of saliva. Well, it's not an overproduction of saliva. It's due to impaired movements of your mouth. Remember, going back to the swallowing in the masked face, everything that happens in our face requires slow muscle movement. Swallowing requires slow muscle movement. Bringing our mouth in to swallow requires slow muscle movement. And whether or not most of us think about it, we are regularly monitoring our saliva. We swallow without thinking about it. We bring our lips in without thinking about it. We are aware when we're drooling, we can quickly bring our lips in if there's more saliva in our mouths. So with the limitation in muscle movements, it isn't unusual for people with Parkinson's to begin to show some drooling. Now, not only is drooling, you know, affects the mouth and can be socially embarrassing, but because you're not swallowing, and when you do swallow, it may not be as effective, drooling can cause choking or aspiration. And anytime we aspirate drool or saliva into our lungs, we have the possibility of, in fact, causing some sort of aspiration pneumonia. So there are a few tips on drooling that I'll quickly give you, and that is suck on hard candy or chew gum. Sometimes that will help. You also need to consult your physician because there are a couple medical things that could be done. Some people will put atropine drops on their tongue. If that's not working, one of the last things that people often do for drooling is Botox injections. Yes, Botox injections. We never think about that, but what happens with Botox injections is it tightens your mouth area, and they can also tighten and give you more control over your swallowing areas. If you have runny noses, try Atrovent nasal sprays, but again, please always consult your physician before you decide to use like atropine on the tongue or the Atrovent nasal spray, because, you know, none of us have one condition in life. We're born with many things. So we want to make sure that what we're doing for one thing that's happening isn't counterproductive to something else that might be happening within our body. So let's take a look at the speech difficulties that also generally come with the swallowing difficulties. Again, remember, slow movement. One of the things that happens because we have slow movement in the respiratory muscles with speech is it can lead to a soft voice in people with Parkinson's. People with Parkinson's who have a soft voice think they are talking loud. So we often get families calling us and saying, you know, my spouse is mumbling, and the other one says, you know, she's not talking loud enough, or gee, the spouse does not have a soft voice, you know, the person with Parkinson's saying, you need to go get your hearing checked. Well, the truth of the fact is, with a soft voice, we need to figure out what are ways to increase the volume of that. So, some tips for speech. There's a therapy called LSVT therapy, the Lee Silverman voice treatment. It is great. You can usually find a speech therapist who knows about it, but the general thing is really, how do you work to project your voice? And people with Parkinson's need to literally think big and think loud. So how do we project our voice? Remind them they need to speak up, speak louder. Singing. Singing is a great thing. We have like a tremble class program at the Parkinson Association where it's just an enjoyable thing where people learn to use their voice. Swallowing. Swallowing is always a problem. It's actually a problem for many people as they begin to age. But with Parkinson's, it can be, and there can be added difficulties with the slow muscle movement interference. So remember to take small bites and sip water after every bite. I'm going to give you a clue. Avoid straws. And the reason we avoid straws is if a straw gets too far back in your mouth, first of all, the liquid is coming in much faster than when you're sipping it, and it comes flying into your mouth, and it hits a part of your mouth that creates difficulty swallowing, so you're more likely to aspirate or choke on that. Always, always, when you begin feeling that you're having swallowing difficulties, let your physician know, because you may want a swallowing evaluation to make sure nothing else is happening. Moving on to the next non-motor issue, constipation. Now, nobody likes to talk about poop, but when it comes to Parkinson's disease, constipation is very real and is experienced by most people living with Parkinson's. It is often a very early sign of Parkinson's, much like loss of smell. And the reason being is when you think about our entire digestive tract, from the very beginning at the mouth to the total back end, it's one big slow muscle. And what isn't working in people with Parkinson's? Slow muscle movement. So consequently, we have to be very, very concerned about constipation. So there are a couple things that we as caregivers, as individuals living with Parkinson's can do. And look what's top at that list. Exercise, exercise, exercise. Exercise is very good to get our muscles moving as smoothly as possible. The second thing we need to look at is diet and adequate hydration. As we get older, we never seem to drink enough water, and it's recommended at least 64 ounces of water a day. And when I say as we get older, we don't really drink enough water, a lot of times this is due to the fact that, gee, if I'm going out, I don't want to have to stop at a restroom, and I don't know if there are going to be restrooms around, so maybe I won't drink water because I don't want to be embarrassed while I'm out. Well, if you are a caregiver and if you are a person with Parkinson's, just plan to stop at every single restroom there is, both of you. It's just a good practice. You know, in this day and age, they're readily available. Water is essential to not only your well-being with constipation, but we'll see later on how important it is. Increase your fiber, bran and prunes. You know, my grandma used to always give me 3 prunes, never more, just 3. I don't know why she chose 3, but anyway, make sure you increase your fiber intake. And as we mentioned, the regular activity. Always remember to think about medications, talk to your physician about this, because lo and behold, if these things don't work, they may recommend some medications. The first they usually are going to recommend is something like as simple as a Metamucil. So another thing that happens with people with Parkinson's is they sweat a lot. So dehydration is critical, a critical concern of people living with Parkinson's disease. So that goes back to, remember, 64 ounces a day. But because of the medications that people are taking, they are at a higher risk for dehydration. And again, if you think that Parkinson's is a movement disorder, otherwise it affects our mobility, the less mobile you are, the less likely you are to drink as much water, because it requires you get up, go get water. Clue, always keep a nice bottle of water with you. But when people run out of water, they may not be as, energetic to get up and go grab that. Symptoms of dehydration are weakness, balance problems, confusion, and the extreme symptoms would be kidney and respiratory failure. Clue: if you are feeling thirsty, you are not drinking enough water throughout the day. You are not keeping regularly hydrated. So your goal is to drink water often enough to avoid ever feeling thirsty. Grab a sip of that water before you feel thirsty. The next non-motor symptoms that I want to take a look at are what we call the neuropsychiatric symptoms. These are the neuropsychiatric symptoms. Typical for people living with Parkinson's are anxiety, fatigue, and depression. Anxiety, fatigue, and depression. Very common in people living with Parkinson's disease. So when we begin to think about the treatments for neuropsychiatric symptoms in Parkinson's, the first thing that comes to mind is, guess what again? Exercise. And not only for Parkinson's disease, but for anyone. When you're looking at anxiety, fatigue, and depression, exercise, and that's the last thing you want to do if you have fatigue. You're going, whoo, but make yourself, even if it's just a little bit. Mindfulness and meditation. Actually, we have a lot of people with Parkinson's report that yoga really reduces their anxiety. And yoga is excellent, not only for reduction of some of the neuropsychiatric symptoms of Parkinson's, such as the anxiety and depression, but also it strengthens your core, which improves your balance. So another type of exercise that is also incorporates meditation that's marvelous. One of the things you want to make sure of around the neuropsych issues of Parkinson's disease, especially if you're having hallucinations or delusions, or check your medication for side effects. Sometimes neuropsychiatric symptoms, and as I mentioned, such as the hallucinations, are actually caused by the medications that you might be taking. So if you begin experiencing any of these symptoms, it is critical that we get people to consult with their physician. One of the neuropsych effects that you might run into are what we call the impulse control disorders. So we see an increase in compulsive and impulsive behaviors. So interestingly, some of the common ones we see with people who have Parkinson's, especially women, are an increase in shopping and binge eating. With men, we see an increase in gambling and hypersexuality. I'm not being, gender biased here. The studies have just shown that between the men and women, these are where the impulsive or the compulsive behaviors begin to occur. We can also see what's called punding, the repetition of useless tasks, such as regularly, rearranging the salt and pepper shakers on the table and things of that sort. As I said, these are often caused by medications. We do hear reports that one of the medications used for Parkinson's, which is Mirapex, may result in an increase in compulsive and behaviors. So I always encourage individuals to, again, talk with their doctor, examine their medications, and see if they need to decrease or change the medications they're taking, or perhaps even add to their medications depending upon what the impulsive issues are. I want to move on to a very sensitive subject, and it is the most confounding or bothersome non-motor behavior or non-motor symptoms of Parkinson's disease, and that is cognitive changes. There are different types of cognitive changes. There's normal age-associated memory impairment. And if I looked at you and said, well, these are signs of, you know, dementia or Alzheimer's disease, a lot of times you begin checking them off and you think when you're actually experiencing normal age-associated memory impairment that perhaps it's dementia. The truth of the fact is forgetfulness of things like not being able to remember nouns is normal as we get older. It is normal not to remember all the details of the event. It is normal to lose your keys, by the way. And I always tell people one of the signs of actual dementia is when you find your keys not being able to remember what they're used for. Cognitive changes can be caused by environmental or personal changes. Moving is an environmental change. The death of somebody so that you have a lot of stress. Cognitive changes can be caused by medications. That's why you always want to look at medications. Today, though, I want to talk about changes in the brain, and specifically with Parkinson's disease, that result in cognitive changes. So let's take a look at the facts of cognitive change in those living with Parkinson's disease. Unbeknownst to a lot of people, an estimated 40 to 80% of individuals with Parkinson's develop dementia. Now that's an incredibly wide range, which tells us we still need to do more research and study into dementia as it relates to people with Parkinson's disease. Unsurprisingly, it's 3 to 6 times more likely that elderly patients with Parkinson's disease will develop dementia than our younger individual. There are certain types of dementia that are common with Parkinson's disease. There's actually a Parkinson's disease dementia. It's related to Parkinson's and changes in the brain around the dopamine and whatnot. Also, we often see a Lewy body dementia associated with Parkinson's. So this is not to say that one could not also have a disease such as Alzheimer's causing dementia. Dementia is kind of, it's a term, it's a generic term. And there are different types of dementia. Lewy body dementia, there's frontal temporal lobe dementia, there's Parkinson's dementia, there's Alzheimer's dementia. But we do know that people with Parkinson's on average will definitely develop some sort of dementia, 40 to 80% of them. Others will just experience kind of some cognitive changes that aren't dementia, and that quite often has to do with executive functioning. So if you are exhibiting signs for dementia, what can be done? The most important thing is to remember that no cure for dementia, or for that matter, no cure for any disease, is not the same as saying you should do nothing. So what do we do to help Parkinson's from affecting your mind? There are 2 words I love: tenacious, because I have found that people with Parkinson's disease are very tenacious individuals, and I say that in the most positive manner you can imagine. And you need to be proactive. So what does being tenacious and proactive, what does that mean? What are the ways that you can help your brain function to its maximum? Ways to help the brain. The first thing that we need to be looking at is social engagement. Some of you may say, I don't like crowds, and I don't want to, be going to all these programs and classes. Well, study after study shows that social engagement really enhances our ability to think. It keeps us sharp. It keeps us on our toes because we have to listen to new things and hear new views and respond to people. Proper feeding and watering of the brain is essential. Look at that. That word water comes up again. Remember, 64 ounces at least per day or more. Your brain, when you become dehydrated, you get fuzzy. So what is the proper feeding of the brain? I sense a lot of you are going, oh, she's going to give me one of those nasty diets. I'm not. What I'm going to say is there are things that are better for your brain and things that aren't as good for your brain. We know processed sugar is not good for thinking. We know it confuses people. And with that in mind, rather than a processed sugar, find out, go to a natural sugar. Use a honey that hasn't been processed. It's really hard to get rid of your sweet tooth, and I'll be frank, sometimes a little bite of ice cream now and then is good for the soul. So monitor how much of the sugars you're eating. Make sure you get omega-3s in your diet. I love it. Everybody turns around and says, oh, sardines give you omega-3. I don't know how many of you want to eat sardines to get omega-3. But, salmon. But there are other things. Look for your vitamins that can be omega-3. Look for foods that are fortified with some of your omega-3. Look at the next thing that's on our list here. Exercise. You knew it was going to come up again. Physical and mental. So this time we're going to talk about mental exercise. We need to keep our brain sharp. And to keep our brain sharp, like any other part of our body, we've got to exercise it. So there's some simple little things you can do. If you're going grocery shopping, most of us grocery shop going the exact same way in the store. I dare you to start in the middle of the store. That's right, start in the middle. It's inconvenient because it's different. It's not the same thing that you're looking at. So with it being inconvenient, it makes you think, where am I in the store? What's on my grocery list? Some people will put their watch on upside down. If you still wear a watch, especially the digital ones, it gives you a start the first time you look, not a digital, an analog. The first time you look at that analog and it's upside down, you think you're late. But it's okay. Your brain's going to switch it in a minute. If you're still driving, take a little different route home. These are just little things that kick you out of your habits. So mental exercise, think about what are my habits and how do I deviate from my habits which cause me to think. Support groups, that's social engagement again. I want to give a plug for support groups here. Too many people think that, a lot of people say, I don't want to go to support group. People whine. What I found at the Parkinson support group is people don't whine. People support. They give you ideas how to live better, how to overcome something that has been problematic. If if something isn't working with your medical care, they'll say, gee, I did such and such, and that really worked for me. It's a great place to find wonderful information and solutions to things that, have been problematic for you. So get that social engagement at a support group every so often. And support groups don't have to be a formal place. Sometimes you have an exercise class and the group goes for lunch afterwards. Well, that's a great support group. So look at the different ways of getting support other than just a formalized support group. Lastly, when it comes to dementia, the typical medications that have been used are donepezil, rivastigmine, and memantine. Well, those typically work with people who have Alzheimer's disease. They're often tried with people with Parkinson's. Sometimes they work, sometimes they don't. It's very hard to distinguish one dementia from another. Always give them a try. Obviously, you have to talk to your doctor, but they might be worth a try. I want to talk about supplements, though, because we hear a lot about supplements to improve our brain. I mean, we are lambasted with supplements every single day. Reminder, always, always check with your doctor. We have memory boosting supplements, and to be honest, there are a few good studies that prove or disprove the effectiveness. If you're taking a memory booster and you swear it works for you, go ahead and continue as long as your doctor knows you're taking it and it doesn't interfere with anything else. CoQ10 is one often recommended for Parkinson's. It's because CoQ10 is naturally occurs in the body, but it's kind of low in people with Parkinson's. Well, with that in mind, remember, consult your doctor, but more importantly, remember, again, there are a few good studies that prove or disprove the effectiveness. Ginkgo biloba, been spoken of for years to enhance memory. Please be careful. It can cause bleeding. Be careful. It can cause bleeding, much like Too much vitamin E can cause excessive bleeding. Here's a biggie, St. John's wort. You'll hear that it is great for memory. Do not use St. John's wort. It interferes with dopamine uptake. And you've got to be able to maximize every single bit of dopamine your brain is producing. So you do not want to use a supplement here, St. John's wort, that's going to interfere with the uptake. There are a lot of medications to avoid, and I really, to try and go into them all. But if you go to www.awareincare.org, you will be able to find listings of medications that you should avoid. So how does Parkinson's affect medical care? How does it affect medical care? First of all, your doctor is your partner, not your boss. I'm going to say that again. Your doctor is your partner, not your boss. So you need to, when we look at medications, discuss all the changes in meds and your response to them and other physical changes that are bothering you. If you experience constipation, you need to talk to your doctor about that. If you're feeling anxious, talk to your doctor. The best thing to do is to regularly keep a journal of what's happening with your Parkinson's disease and what's happening with your response if medications were increased or decreased or you suddenly started taking a different supplement. The reason I say keep a journal is, when we get in the doctor's office, we have, 15 minutes if we're lucky, maybe 30, that'd be great. But if you keep a journal and you have it with you, you can look at the doctor and say, this, and this is happening, and this particularly bothers me. What can we do about it? So it's important to remember the doctor can't help you unless you do your part of the partnership and talk with the doctor and become a true partner. One thing that is critical to remember for care partners and caregivers and if people are living in assisted livings and whatnot, medications for Parkinson's, they must be taken on time. If you are living in a care community such as an assisted living, or somebody is helping you with your medications, reminding you to take them, they've got to be taken on time. In a care community, they have a 2-hour window by law to give you the medications. If your medication is an hour late, if you're supposed to take it at noon and their window says, hi, I have until 1 to take it and it's an hour late, you can actually end up freezing. So lastly, when possible, always consult a movement disorder neurologist. Always just consult a movement disorder neurologist. They specialize in Parkinson's, MS, and other things such as essential tremors. To ensure that you don't get a wrong medication when going into the emergency room if something else were to happen to you, again, look up that Aware in Care kit we just talked about at awareincare.org. They'll give you all the tools that are really necessary when you enter into an emergency situation. So I want to end today with a quote from Michael J. Fox. As we await the discoveries, we have the human spirit. And that's really what we're talking about today, is how do we energize, how do we capitalize upon the great human spirit, upon the tenacity that so many people with Parkinson's demonstrate, in terms of living well. That comes from within. And when we are, as family members, as caregivers, or whomever interacting with a person with Parkinson's, as well as the person with Parkinson's, we need to figure out what is it we can do to live with Parkinson's, because this is a chronic disease. It's a progressive disease that many of our constituents at the Parkinson's Association have lived with for 20 or 30 years. So harness that spirit early. And lastly, to end today, the thing that I'm constantly reminded about in life, whether we're facing Parkinson's disease, Alzheimer's disease, cancer, anything, it's all about the attitude we bring to living with the disease. So thanks. I'm hoping that we've got some questions going here, and I've thoroughly enjoyed my time with all of you.
Thank you, Cheryl. That was very in-depth and informative. We appreciate everything that you provided there. A couple questions that came up during the conversation, during your presentation there. The first one, you listed a bunch of symptoms that on the iceberg picture, you had a bunch of symptoms that were in essence below the water. Of those symptoms, are there really anything other than some of the suggested strategies that you provided? Are there any medications or anything that can help with some of those symptoms, or do you find that most of the focus has been on the ones above the water?
There are definitely medications that can help with some of the symptoms that are below the water. I know we talked about further drooling and whatnot, the atropine on the tongue type thing. For hallucinations or delusions with Parkinson's, there is a new medication that has come out. It's called Nuplazid. It is an antipsychotic that is very specific for people living with Parkinson's. Many of the drugs that are currently being used in the antipsychotics are really contraindicated for people living with Parkinson's, although they will always be tried for anxiety, depression, and those type of things. When we begin looking at things like the orthostatic hypertension, there are medications for that. I believe Northera is one of those. Mind you, I'm not a doctor, so that's why I always say make sure you consult your physician. You know, pain is another one that's a very interesting thing. A lot of the pain is caused from that rigidity. Sometimes it's like a dystonia, like a curling over of the toes and things. Definitely consult your physician with that. I think one of the questions I get most often, if you want to know the truth and whether or not you consider it a medication, is really around marijuana, living here in the state of Colorado. Good. Marijuana in and of itself has not been shown to affect the progression of Parkinson's disease. More and more research is being done on it. Certainly we know that research has been done on marijuana and pain, and some people report that it's very effective. People with Parkinson's will sometimes report with that dystonia that it provides some comfort. We've had, you know, anecdotal comments from people living with Parkinson's around, again, the orthostatic, not the, around the, whoa, just lost that. We'll come back to that. We'll find out where my brain was going. Urinary frequency, a lot of times it's a matter of, you know, feeling they need to urinate frequently. Again, I would consult a urologist around that. I recently, I mean, there are all sorts of tricks, of course, but I recently heard somebody that, although it's seldom used, but using Botox treatment for that, which is an interesting thought. Regarding the sexual dysfunction, I'm not as familiar with the medications that might be used for that. It's going to be your common medications that are used for other sexual dysfunction type things.
Right. Another question probably along those same lines is, are you seeing from a research and development standpoint, I know with Michael J. Fox being involved, you've probably seen a little bit of an uptick in the advancement of money coming into this disease state, but what are you seeing? Has that kind of slowed down a little bit, or are you seeing the R&D continue to develop?
The R&D through the Michael J. Fox Foundation and other individual supporters of research is definitely increasing. I think Michael J. Fox Foundation has done a fantastic job. Our biggest concern is practically as we speak right now, you know, we're looking at what is going to be the funding from the NIH and in the National Institute of Health. And the NIH funding is kind of dropping off. We have to regularly advocate for, to maintain the same level. One thing I will share, though, is when we ask this question, we think just about Parkinson's disease. I think we need to expand that for R&D for all neurological diseases. We're seeing a lot more research being done in conjunction with both Parkinson's and Alzheimer's disease, or Parkinson's and another disease. And I firmly believe that any of the research that is being done for neurological diseases in general will help us find a cure, and even, find new medications and whatnot for people living with Parkinson's. Just as our Parkinson's research, I have no doubts, will, also affect perhaps treatments for MS or, ALS or other neurological-based diseases. So I think if we look at the larger pot in general, we are seeing increased funding because we are seeing increased awareness, especially as our population is aging. Because when you start talking about Alzheimer's and you talk about, Parkinson's disease, you're talking about what they refer to as the silver tsunami, who's, taking up healthcare dollars.
Yeah. Hey, so you mentioned towards the end of the presentation associated with neurologists that have, the muscle or muscular disorder type of specialties, Parkinson's, MS, maybe muscular dystrophy, some of these other ones. Do you find that specialty is available along the Front Range and maybe even statewide? We're a statewide agency, so the curiosity would be, is, for example, I'm out here in Grand Junction. Are there those specialties in some of these smaller communities, or are you finding that you have to come to the Front Range to access that specialty?
Obviously, the majority of the movement disorder specialists, neurologists are on the Front Range, and again, most of them are working in the Denver area. In the Grand Junction area, there is a great movement disorder specialist who can help, who's serving more than just Grand Junction. I understand that he actually is down in Durango at times. That is Dr. Seth Carius. He is a movement disorder specialist.
Okay.
But I think that is the Cadillac. It's like, we find results of people receiving care from movement disorder specialists. They have improved results over just a neurologist. But the important thing is, if you're seeing a primary care doctor, you need to make sure you get connected at minimum with a neurologist, because they are going to have a better understanding of monitoring medications and how to treat Parkinson's. If you have access to a movement disorder specialist, that is great. But you are absolutely correct. In our outlying areas, it's very limited as to how many movement disorder specialists we have.
Great. Well, hey, we're bumping up against our time here, Cheryl. Looks like that was the last question. So I want to thank you for your time, and wow, what a lot of information for our caregivers and our staff and the potential clients out there to peruse through. Again, Devin will be placing this recording and these slides out on our website probably within the next 24 to 48 hours. So I would encourage you to go to the website and review this or recap on it. Cheryl, I'm assuming you're available for questions in the future, or some members of your team would be at the Parkinson Association.
Absolutely. Just either go to the website, you've got my email address, the website, or you can give us a call at 303-830-1839.
Wonderful. Well, Cheryl, thanks again. We certainly appreciate all the information and your outstanding ability to present it. It was great. Thank you again, everybody, for your attendance to Community Connections for September. Community Connections for October will be on October 11th, same time, 1 p.m., and we look forward to having you join us then. Again, have a wonderful day, and we will see you next time.